மீட்டிங் இல்ல இப்ப இங்க இருந்து போகுதா இப்போ இங்க இருந்து सीएमसी ऑडियो पूरा बुक ही है उसमें जगह ही खाली नहीं இப்போ நாம சொன்னதுக்கு ரிக்வெஸ்ட் பண்ணது யாரு ஓகே நாம சொன்னதுக்கு வாட்ஸ்அப் பண்ணது வந்து ரமேஷ் பிரபஞ்சன் அவர் பேர் என்ன ஓகே இப்போ இவர் பண்ணது அவர் தான் இப்போ நாம் பண்ணது லைஃப் ஸ்டைல் ஆகலையா இன்னும் ஓகே होटल का हमने ट्राई किया था लेने की मगर अब होटल में रूम ही नहीं तो कैसे करेंगे No, sir, from CMC Velos, CMC Velos.
Sir, good afternoon, sir.
Sir, are you able to hear us?
Ramesh, sir.
Ramesh, we are good to go.
From CMC Velos, are you able to hear us?
Yes, sir, we are able to hear you.
Sir, I'm expecting a reply from CMC Velos, sir.
Yes, yeah, we can hear you, we can see you, picture is clear, thank you. We are ready to go.
Yes, sir, loud and clear. It starts. Good morning, one and all. My name is Dr. Vishwant, final year postgraduate from Madras Medical College. Taking a long case. Selvi, a 45-year-old female who is a homemaker from Chengalpet, presented with chief complaints of low back pain for the past 2 years, and pain radiating from buttock region to the left posterior aspect of her leg for the past 2 years. And over the past 6 months, she has complaints of pain in the right leg after walking for a distance of 100 meters, which is relieved on rest and sitting. Patient was apparently normal 2 years before, after which she had a history of self-fall from stairs, after which she sustained injury to her back. Following which, she went to a nearby hospital and she had taken medications, after which the pain subsided. Over the last 8 months, she has been having continuous pain, which is insidious in onset, progressive in nature. That non-laking type of pain, insidious in onset, progressive in nature, aggravated by doing strenuous work and standing, and it is relieved by rest. Patient has history of pain radiating to the right lower limb, the posterior aspect of the right lower limb. Patient also has history of pain in the right leg after walking for a distance of 100 meters, after which she cannot walk anymore. There was no history of any weakness. There's no history of numbness. No history of any deformity. There's no history of early morning stiffness. No history of bone maturation. No history of loss of weight, loss of appetite. There's no history of any other medications taken for any other drugs. Any other medications. Past history. Yes. Yes, sir. So she's able to walk for a distance of 100 meters, sir. After which she's sitting down. After some time, again, she's able to walk for a certain distance, sir. But the distance is progressively being reduced. Clarification.
Sir, Dr. Karthikela, sir, audio is not, we are not able to hear, sir. Sir, I think it is kept on mute.
Okay, can you hear me now? Can you hear me now, guys?
Yes, sir.
Yeah. Yes, go ahead. So, neurogenic claudication type of things.
How will you neurogenic and vascular?
Neurogenic type of pain starts from the proximal and goes to the distal, sir. Vascular starts from distal to the proximal, sir.
Okay.
In neurogenic pain, the walking distance is not constant, sir. It is variable, sir.
Yes, okay.
In claudication pain, in vascular claudication, the walking distance is constant, sir.
Constant. Okay. In this patient, does it associate with any neurological symptoms?
Yes, sir. She has difficulty in walking, sir.
No, no, tingling or any numbness, anything like
No,
that.
sir.
No. Only testing with the radiation. That too goes to 1 month. Distance?
Yes, sir.
Variable?
Yes, sir.
Okay. And severity is
Severity is increased.
That's what it is.
Yes.
Okay. Any bowel and bladder disturbances?
No, sir. No bowel and bladder disorder.
No
No bowel and bladder disorder.
bladder disturbance. Any cause, history of symptoms like something like that?
No history of fever, no history of loss of appetite, no history of no other functional symptoms.
Okay. Right.
No, sir. No, sir. No, sir.
Yes. Proceed.
Past history, sir. The patient no history of diabetes mellitus, hypertension, bronchial asthma, epilepsy, or no history of any drugs taken for tuberculosis. Treatment history. 13 years back, patient had a history of road traffic accident, following which she was 1 year later she went to a private hospital and she was diagnosed to have a back problem and surgery was done, sir.
Can we please request all other mics to be muted except the person who's presenting? There's a lot of background noise. Can you please mute all the other mics? Thank you.
So, to any history of tuberculosis which could affect the
any conflict with symptoms, anything pertaining to tuberculosis or anything, isn't it? Either in your presenting history or in your past medical history. So why would you jump into this at this point of time? When you're going in for trouble, I'm going to ask you, did you ask the seizures? Right? Why is it relevant for me in back pain? Why is seizure medication important for me in back pain then? So don't jump into something because in exam, you get into trouble. You need to ask the questions. Okay. Right. So stick to details. Don't go into something that is unnecessary.
Yes. Treatment history also. Personal history. Patient has normal bowel and bladder habits.
You said she underwent some surgery in the back.
Yes, sir.
Okay. The complaint at that time.
So she had a history of road traffic accidents, sir.
Following traffic is a very vague.
Yes, sir. Following which she developed low back pains.
Low back.
She had low back pain.
Low back pain, right?
Low back pain radiating to right lower limb, sir.
It's the same complaint or a different complaint?
Same complaint, sir.
Same complaint she had, that is 13 years back.
Yes, sir.
For which she was operated. Some
Yes, sir.
of it has been done on her.
Yes, sir.
Okay, so she was symptom free till now. Again, symptom free for particular some time, but
Yes, sir.
now the complaint she recorded.
So again, she had a second history of fall, sir.
Fall.
2 years back.
Okay. Right. Okay.
Yes. On examinations, patient is conscious.
Can you summarize your findings in the history? Can you summarize?
So patient,
For history, yes.
so patient has low back pain radiating to right lower limb, sir. And she's not able to walk after walk for more than 100 meters since without pain in the legs, sir.
Okay.
Which is relieved by forward bending, sir.
And by forward. Okay.
Yes, relieved by forward bending, sir.
Yes.
And relieved by rest, sir.
And she had a positive history of some surgery done. Yes, not.
Yes, sir.
This is it forward bending or crouching?
So,
Forward bend.
yes.
Okay.
On examination, patient is conscious, oriented, equilibrium, well, moderately built and moderately nourished. No items of any. Yes. Yes.
What do you think the pathology being looking?
So, lumbar stenosis. So 45, sir. Yes. Sir, probably because of the disc, it could have been totally because of a huge disc, it can lead to stenosis.
How often do you see a traumatic disc causing stenosis, surgery, stenosis? So is that a common thought process you should have?
Yes.
No?
Yes.
Okay. Go on.
Yes.
No neuropathic markers seen. No features of generalized ligament laxity present, sir. On inspection, inspecting the patient in standing position. But general examination. Yes. Yes, sir. Yes, sir. Sir, my tip of the thumb, sir, the patient is not able to touch them. Yes. Patient standing position, with body, inspecting from back, head centered over the sacrum, normal hairline, bilateral shoulders at the same level, bilateral scapula at the same level, bilateral arm to trunk distance, bilateral arm to trunk distance is normal, bilateral anterior superior, bilateral ear crest at same level, 8 centimeter heel linears of the surgery seen, sir, lower lumbar region. On palpation, inspection from the front, bilateral nipples at the same level, bilateral anterior superior iliac spine at the same level. No neuropathologic markers. Markers which like or neurofibroma, so actually start
Can you, sir, am I audible there, sir? Sir, Venkatesh, sir, oh, sir, can we, sir? Sir, is it audible, sir?
No, we lost the connection for a little bit. Sorry about that. So, where have we reached? Have we reached examination? Sorry, investigations?
No, sir, no, sir. We just finished the inspection findings, sir.
Okay, inspection findings. Okay. So,
Okay, I
so,
will,
this- so in summary, she has had a surgery in the past for
Yes.
similar symptoms 15 years back.
Yes, sir.
And now she has come with recurrent symptoms, which is, I forgot, is it back dominant or is it leg dominant?
Both are present, sir. She's got leg pain while after walking for a distance of 100 meters.
Okay, but how much of pain, mechanical back pain does she have? So what kind of pain does she have? Does she have mechanical pain, radicular pain, claudication pain, referred pain?
So
What pain does she have?
she's having radiating pain and claudication pain is also present, sir.
Okay, what about mechanical pain? Any instability pain she has?
No, sir.
No.
No, sir.
So VAS, have you told us the VAS, visual analog score? What is the VAS for the back and for the leg?
No, sir. I'm
With
not told,
rest
sir.
and with activity.
I'm not told, sir.
You have not scored. Okay, right. Okay, what do you think? Just tell me. You have seen the patient. Just tell us. What do you think?
She's pretty comfortable at in normal position, sir. She's not got any instability pain, sir.
So she's more of leg dominant symptoms.
Yes, sir.
Okay, fine. Sure. So how far have you reached in examination?
So inspection, sir. I've completed my inspection and palpation, sir.
You're going to palpation now.
Inspection, sir.
Sure. Continue.
Repeat the finding again.
On inspection, patient in standing position with both arms by the side of the body, head centered over the sacrum, hairline is normal, bilateral shoulder at same level, bilateral scapula at same level, both shoulder at same level, both scapula at same level, and the arm to trunk distance both sides is normal, and iliac crest is bilateral iliac crest at same level, and linear surgical scar present in the lumbar region, sir. On palpations, inspection findings confirmed in palpations, sir. Inspection from front, sir. So inspection from front, bilateral apical at same level, bilateral anterior superior iliac spine at same level. And palpation, there's tenderness felt over the lumbar region over the L4 and 5 vertebra. There is no palpable step present, sir. There's no palpable step present. No paraspinal muscle spasm seen, sir.
Okay.
Yes, sir. No swelling, no scar, no swelling, no sinuses, and skin is normal, sir.
Where is the tenderness you said?
So tenderness is present over the L4 and L5 vertebra, lumbar vertebral bodies.
Over the spinous process.
Yes, sir.
L4 and L5
Yes, sir.
tenderness.
Spinous process. Sir,
The heel scar. Heel scar.
it's heel scar, sir.
Okay.
Sir? Yes, sir. Tenderness is there, sir. Over there. Yes, sir.
Can I ask some question from here? Can I ask?
Yes, sir.
Yes, sir. Yes, sir. You are, yes, sir. You can ask.
Yeah. So you said the scar is how many centimeters?
Sir, 8 centimeters surgical scars.
Okay. So where do you think the surgery was done? Which level? Based on your palpatory and inspectory finding.
It was done lumbar vertebra, sir. L4 to L3 to L4, L5 region, sir.
So you mean to say that all these levels have been operated?
Yes, sir.
Is it any other way of finding out that which level they would have done? Looking at the palpating the scar? So what is the thing you will feel for? When you are palpating the back, what is the thing you are feeling for? Which bony structure you are feeling?
Spinous process, sir.
Spinous process.
Yes, sir.
So which is the first thing usually will be removed when you are
Spine.
doing spine surgery?
Sir, spinous process will be removed, sir.
Spinous process. So do you feel any gap or any missing spinous process?
No, sir.
So that means no spine surgery has been done for an 8 centimeter incision. So palpate it again and see whether are you feeling all the spinous process, or is there any spinous process which is missing there?
யூஸ் பண்ணிக்கோங்கம்மா. So let's see this card. Yes. Okay. So this is spinous process. Yes. 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 You come down here. We are not feeling it. Yes. Yes. So it's been 6 to 10. Yes. So not able to palpate the spinous process clearly. Yes. As compared to. Yes, sir. Yes.
Yes. What are your findings?
A video.
No, sir.
English,
Yeah, proceed, please.
Sir, I'm not able to palpate the spinous process, sir. Sorry, sir.
Okay, from where?
Sir,
Where to where?
from L4, L5, L3, L4, and L5, sir.
L4 and L5.
L4 and L5, sir.
Two spinous processes are missing.
Yes, sir.
How did you find out that two spinous processes are missing? How did you know that it is L4 and L5?
Sir, I palpated the spinous process from above, sir, and from the corresponding to the anterior iliac crest L4 vertebra, sir, and from that I calculated it, sir.
Okay, so highest point of the iliac crest corresponds to L45 interspinal space.
Yes, sir.
Okay, so from there you calculated. Any other way of calculating? If you are calculating from the top to bottom, how will you calculate? From top to bottom. So which is the most prominent spinous process?
C7, C2. Sir.
C7. Okay, fine. Then which is the next landmark for the spinous process? Superior angle of the scapula corresponds to
T2, sir.
T3. Okay, inferior angle of the scapula corresponds to
T7, sir.
T7. Okay, and your PSIS corresponds to so you should know these anatomical landmarks to count.
Yes, sir.
The highest point of iliac crest is the last one to be counted because that unless you flex the spine leg fully, the highest point of the iliac crest will not correspond to the L45 spinous process.
Yes, sir.
Okay, fine. So you mean the spinous process are missing. So in palpatory finding, this is the most important thing. If a patient has been already operated, which will let us know. Okay, anything else you want to see? Does the patient have any implant inside?
Sir, as per history, sir.
As per history, she says no,
Yes,
but
sir.
they'll say, I don't know.
Yes, sir.
Okay, so how will you find out? Where will you palpate to see, feel for the implant?
Anything in the paraspinal region?
So you should feel the paraspinal region for any prominence, implant prominence.
Yes, sir.
Okay, fine. Proceed, please.
Yes, sir. So on moving, sir, patient is able to
The audio.
sir.
So can I proceed now, sir?
Hello, sir.
Yes, please proceed.
Yes, sir. One movement, sir. Patient is able to forward.
What are the movements you are checking, especially as far as pain is concerned? First, we look for
Cervical region, sir. The cervical region, we have to see for forward. Sir, here we have to see a forward bending in the patient, sir. And we have to see whether the patient is able to touch
flexion. Okay,
flexion, sir.
Where does flexion extension takes place in the spine?
Sir,
Where does flexion extension take place in the spine?
extension, sir.
Flexion extension movements, where does it take place? Thoracic region or lumbar region?
Sir, lumbar region.
Lumbar region.
Yes,
Okay,
sir.
rotation,
Thoracic region.
thoracic region. Okay, right. So how will you assess the flexion extension?
Flexion section happen in the lumbar spine, in thoracic spine. Rotation in thoracic spine. What is the reason? The last one is
Yes, sir.
They are aligned.
Yes, sir.
what is the surgical?
The
Facet.
orientation.
Yes, sir. Special orientation, sir.
Lumbar orientation.
Vertically oriented in lumbar spine.
Yes, sir.
Horizontally oriented in
Thoracic spine. Thoracic spine.
the rotation happens there.
Yes, sir.
And flexion extension happens in the lumbar spine.
Yes, sir.
So facet orientation plays a role in movement.
Yes, sir. Patient is able to bend forward and touch the floor without bending her knees, sir.
Okay.
And then laterally, patient is able to sideways from able to touch up to the knee joint without bending, sir.
Okay.
So,
Okay. Is there associated with any pain or any paraspinal spasm
no, sir.
or any numbness or nothing?
No, sir.
Okay. But she is able to do these movements
Yes, sir.
without any.
Without any pain, she is able to do this movements.
Okay.
What is the name of the test? You said the movement.
Yes, sir.
When the patient forwards,
Yes, sir.
is there a name test? Anyone?
Shoulders test, sir. Shoulders and modified shoulders test.
What is shoulder? What is modified shoulders?
Modified shoulders test. The one line is drawn at the posterior superior point. 3 points are drawn, sir. One at the level of posterior superior iliac spine, sir, and one 10 centimeter above the posterior superior iliac spine, and 5 centimeter below the posterior superior iliac spine, sir. And after this line, the patient is made to bend forward, sir. And the difference of more than 5 centimeters is normal, sir. And so less than 2 centimeter is normal, sir. Patient will have any so yes, sir. Only sir. No, sir. Patient has no limitations.
No limitation.
No limitations, sir.
Shoulders, we mark the spinous process or the skin marking?
So
I'm asking, what is the limitation? Do you have any limitation or any group of patients where you cannot properly elicit shoulders?
When can you not apply shoulder test?
Do you understand?
See,
Yes, sir.
what I want to emphasize is that shoulders, we don't mark the spinous process. No pushing points are being marked.
Yes.
To elicit direct movements, it's only the skin marking. So when the patient is fatty or very much obese, skin is floppy,
Yes.
you will not be able to elicit exactly what you really want to do. And one more thing, as a doubt, all the range of movements in this patient is free and equal. History, you said she had relief on bending.
Yes.
I consider extension is going to be painful for her.
Yes.
So now you say all the range of movements are free and equal.
Extension is painful, sir.
How much? Check.
Sir. Neurological examinations, sir. So patients higher motor functions are normal, sir. Cranial examinations are normal, sir. And the motor examinations, sir. Right-sided L2, L3, and L4 levels. Sir. L2, L3 levels. Right side is motor side by face. So left is also yes, sir. Yes.
Why are jumping savings?
Cervical patient has no neurologic tests. C C5, C6, C7, C8, T1 bilateral power is 5 sir. In here to L2, L3 and L4 sir. L2 and L3 bilateral power is 5 sir. L4, L5, S1 right side power is 4 sir. Yes sir. L2 is reflection sir. L2 is reflection sir.
So what are the mediums of reflection?
Sir, Ilios was
Secondary,
lumbar muscles. L3 is heat friction knee extension, sir. L3 knee extension. L4 is ankle dorsal flexion, sir. L5 is great toe extension. S1 is ankle plantar flexion, sir.
okay. So you very important for you to know primary and secondary.
Yes, sir.
So be very sure of it.
Yes, sir. So patient has 4/5 power in L3, L4, and L4, L5 is one. Right side is power is 4/5, sir. Left side is 5/5, sir.
12/5 is good thing or is it not any reason?
So
Is it significant?
it's significant, sir. Significant because stenosis, sir.
For stenosis. You haven't come to that far.
Yes, sir. Sorry.
Okay.
Yes. Yes. Reflexes, sir. Reflexes, right side and knees are reflex.
Sensory have completed.
Sensory level, sir. Patient has decreased sensation over the L5S1 L5S1 region, sir. All the other regions, patient sensation is normal.
Side,
Sir, right side, sir. Yes, sir.
what is L5 dermatome?
Sir, L5 dermatome is the first web space, sir. The first web space is normal, sir. Sensation is diminished, sir. Okay. Dorsum of the dorsum, sir.
Okay. This one,
This one is the lateral border of the foot and the posterior, sir. Lateral border of the foot, sir.
and
And to the posterior aspects, sir, of the leg and thigh.
what are autonomic zones?
Um, now that supply specific areas of specific areas of innervation, sir.
Okay.
Yes.
So what's autonomic zone for this?
Autonomic for L5 is first web space, sir. Or dorsum aspects.
Right.
Yes. And examination of reflexes, sir. Knee reflex, sir. This 1+, sir. Patient is on the right side and the left side is 2+ normal, sir. And the ankle reflex is also 1+ on the right side. So left side is 2+, sir. And plantar is equivocal, sir.
Once again. What is 1+?
What 2 is normal, sir. In
2+ is normal.
yes, sir.
1+.
So
Who's getting?
See, 1 and 2 is about sustained clonus
yes, sir.
with hyperreflexia. Okay. 1 is partial, 1 is complete. 2 is normal.
So,
So you mean to say the patient has got some clonus with hyperreflexia.
yes.
Then now this will go on for
So you expect you are going to element.
Element types. Lemons. Yes, sir. So, yes, sensation reflexes. Yes, sir. So, test for nerve stretching. So, test for nerve stretching, sir. Straight leg raising test is special test, sir. Straight leg raising test is positive on the right side, sir.
so before going to
Yes, sir. கொஞ்சம் நேரம் பார்த்துக்கிறீங்களா
See. Vishnu,
Yes, sir.
there is no positive or negative statement. You have to say the degree, yes, sir, compared to the other leg.
30 degrees. SLRT straight leg raising test is 30 degrees in compared to opposite.
Just demonstrate.
Yes. கால் எடுக்கணுமா? Now she's having pains. No, yes, sir. Yes, now she's having pains. Yes, sir. Yes, straight leg listing.
So what's the next thing you do?
Sir, we go for boosting test, sir. Boosting test, sir. Yes, sir. Yes, sir. Lessig test, sir. So after the during state leg raising test, when she complaining of pain, sir, after we do 10 degrees, we extend the limbs, and after 10 degrees, we dorsiflex the ankle, sir. She's having pains. Yes. Then boosting test, sir. Yes, sir. Sir, popliteal region, sir. So, sir, only single lateral popliteal loss.
Really, what is the basics of SLRT?
Sir,
We have done SLRT. What is the basic behind this?
sir, see,
Actually, what does it? Okay, what you are testing by doing this?
so SLRT is measured from 30 to 70 degrees, sir.
Okay.
0 to 30 degrees, the nerve is slack, sir.
Yeah.
So we will not be able to measure it, sir. From 30 to 70 degrees, when the nerve sets, sir, we see the pain, sir.
Okay.
And after 70 degrees, the pain is supposed to only from the joints, sir. Mostly comes to
So up to 70, you have to say.
yes, sir.
Okay, all right. What are the false positives in SLRT? When will you get a false positive? Okay, if SLRT, okay, up to 30 degree, you are getting SLRT, means what do you think in your mind? Generally,
Yes, sir. So
for example, what you are SLRT, okay, patient feeling the pain.
yes, sir.
What do you think?
Patient has no stretching, sir.
Where? Okay, no stretching where? In what all other positive condition, you will get a positive SLRT. Okay, go ahead.
Yes, sir.
Can you ask the patient to sit?
Okay, ஏன் உட்காந்துக்கிறீங்களா?
With limb extended.
Sir?
With limb extension.
இல்ல கால் பார்த்துக்கோங்க.
I asked her whether she is feeling comfortable.
இப்போ உங்களுக்கு வலி நார்மலா இருக்குங்களா? வலி இருக்கு.
இல்ல கண்ட்ரோல் போது இப்ப இருக்கிறது வலி பரவாயில்லையாண்ணா? பரவாயில்லையா உங்களுக்கு? தடுக்க SLRT?
Thirty degrees, sir. So 90, 90, sir. Now she's yes, sir.
So I don't consider probably my finding the. We'll go ahead.
Sir.
What is something?
Sir. Sir. Yes,
Can you make it?
yes, sir. Yes, sir.
Demonstrate.
That is one way. This is good. Hold on. The other way is put the knees plane flexion, both the knees in flexion. Get it down. You can't divert her by any means of talking or anything like that. You try to passively extend one of the knees. So she leans backward. Then the circularity is going to be positive for her. Just try doing. I don't think, but for her, I don't think it's going to be fast. So Vishwa, do you want to change anything? Change any findings? Do you want to change any findings?
Yes, sir. Yes, sir.
Okay, other leg. So if pain is producible at 30 degrees, this much is not going to be possible.
See, what is one explanation you can give? Are you sure that she had pain at 30 degrees?
Sir,
What is your diagnosis now? Possible cause of this leg pain, this right leg pain,
lumbar stenosis, sir.
lumbar canal stenosis, lumbar spinal stenosis. Okay. So sometimes when you examine the patient would have had pain. Now the patient is lying down relaxed and slump test is done and she's not having pain at 30 degrees. Until 90 degrees she's comfortable. So here is where you can exert the patient, ask her to do sit-ups and stand or ask her to walk to and fro. If it is a claudication as per your diagnosis, then once the patient is being exerted for some time, then she'll reproduce radicular symptoms. So after lying down comfortably, relaxed, you will not have the SLR. You understand this? So that is one way you can try. And she might have pain if she's walking to and fro for 10 times or sitting and getting up. When she'll be when the nerves are the blood supply to the nerves are decreasing, then she'll have reproduction of the symptoms. Okay.
Yes, sir.
And Vishwa, with unilateral radiculopathy, don't lumbar stenosis.
Yes, sir.
It's parameter.
Yes, sir.
Unilateral radiculopathy you are presenting and lumbar canal stenosis, it's not.
Well, part of the- Another part. So posterior aspect of the thighs and back. Yes, sir. Yes,
Go ahead. Okay, go ahead.
yes.
Yes.
So any questions from CMG team, sir? Video call, right?
No questions, sir. No questions. Please proceed.
Yes, sir. There is no on the measurements, sir. Patient chest expansion is of 4.5 centimeters, sir. And while there's no bilateral one, there's no limited discrepancy, sir. And muscle wasting is present on 1 centimeter muscle wasting present in the calf compartment, sir, compared to the left side, sir. And there's active hormones are present, the distal pulse and bilateral distal pulse is present, sir. Also,
What are other things you have to? What is the goal? Like,
sir,
yes.
patient is having antalgic gait, sir. Patient is
Antalgic, then you have to be very careful.
Antalgic gait, where you think the pathology would be?
hip, sir. She's having a short stance face, sir. While walking, she had a short stance face. Sir, bilateral hips are normal, hip joint is normal, sir. Yes, sir, full range of movements.
SI joints.
And bilateral SI joints are
Yeah.
normal, sir.
Yes. What's the diagnosis? Prone test.
Sir,
The prone test
Yes, sir. For femoral nerve stretching test, for L2, L3, femoral nerve stretching, we do it in prone positions. Yes, sir.
Check. Right wheel for vision.
Yes, sir.
Try the pain beat. L3, L4 lesion.
Yes, sir.
Where will your pain be?
Pain around the middle aspect of the legs, sir. L2, L3 down,
Thigh pain, the leg pain.
leg pain,
This is going to be one.
leg pains. Middle aspect of thighs, sir. Sorry, thigh pains,
But usually thigh pain,
leg pains.
leg pain. Okay,
Yes, sir.
upper levels. So you can do two tests for that.
Yes, sir.
What is the Faber
Yes, sir.
and what is the
Cancer
test?
Gansen test, sir. Favorite test, sir.
Okay, Faber one. You said Ganson's.
Yes, that's why I say joints.
Yeah.
Yes.
Or what's called Patrick's test.
Yes.
Flexibility, performance systems for a higher level of risk.
Yes.
Okay. Right. So what is your final? Summarize your findings and give us a clinical diagnosis.
So 45-year-old female, sir, who's having low back pain relating to right lower limb for past 2 years, sir. And she's having claudication pain. She's not able to walk for more than distance of more than 100 meters. Sir. And on examination, she has got a neurological deficit, sir. Neurological deficit is present.
What is it?
So,
Summarize your findings.
yes. Yes, sir. Straight leg raise testing is positive, sir.
Just now, the amounts very clear, but stamp is negative. You're sitting quite comfortably. So you want to change your finding there. Right.
So most probably due to claudication, sir, due to L3, L4 stenosis, sir.
You still want to stick to stenosis. Okay.
So one thing what I want to know is that, was there a period of relief? How long was the patient, symptom free from the first surgery?
So from the first surgery, she was symptom free for a period of 10 years, sir.
10 years.
Yes, sir. After which she had a second fall.
Wow.
Fall.
Okay. Yeah, summarize.
Yes. So her so on the special tests, the positive, sir. Yes, sir. So history, she got claudication pain, sir. So she has
So summary is that,
yes, sir.
it's a 30 or 35 years old female,
45-year-old female,
with now presenting with
it's a 45-year-old female who presented with chief complaint of lower back pain relating to right lower limb, and who had pain while walking for a distance of 100 meters, and she was entitled to fall. And she was operated for and
with the motor deficit at
which is with motor deficit at L4 and L4 L5 level, L4 L5 S1 levels.
and sensory blunting
So sensory blending at L5 S1 levels.
with intact bowel and bladder.
With intact bowel and bladder habits. With it's intact bowel and bladder habits. Yes.
So conclusion.
Probably could be due to
So, stenosis of L3, L4 stenosis or
L3, L4 stenosis.
yes, sir. Yes, sir. Yes, sir.
Yeah.
Standard.
Yes, sir. Secondary.
Lumbar canal stenosis
Yes, sir.
secondary to
Secondary to so
they have gone for instability.
yes, sir. Yes, sir. Instability.
There is a pain over that area.
Yes, sir.
Already it's operated. Most spinous process that. Can we call it the failing back syndrome?
Yes, sir. Yes, sir.
How can you call it failed back syndrome, sir?
Intervention was previously patient was operated upon, sir. And now yes, sir.
What define failed back syndrome? Failed back syndrome is defined as pain or symptom recurring within the period of 6 months following the index operation.
Yes.
This is 10 years survival rate in the attribute of failure.
Yes.
So you cannot label it as failed back syndrome. Okay.
Yes, sir.
So your choice is now, say, lumbar canal stenosis.
Yes, sir.
First, operatively, she could have fibrosis or she could have a stenosis at a level
Levels.
spasm.
Yes,
That should be a different thing.
yes, sir.
So, Kenny, sir, anything else you want to add, sir?
No, I think everything has been covered. But just for the interest of all the postgraduates, I wanted to just say that, when you present a diagnosis, it should have some components. One is the syndromic component. There is a syndromic diagnosis, there is an anatomical diagnosis, and there is a pathological diagnosis. So in this case, if it is neurogenic claudication, that is your syndrome, or radicular pain, or mechanical instability, though that is the syndromic component of it. Then you go to the anatomic component, which is L3, 4, 4, 5, whatever you say. And finally, pathology, whether it is instability, whether it is degenerative stenosis, whether it is disc, whether it is, whatever it is, spondylolisthesis. I mean, those are all pathological diagnoses. So all those three components have to figure in your diagnosis. That is when you can say you have a complete, that is how the neurological diagnosis is presented. If you see a neurologist presenting, a neurology PG presenting his, it usually has these three components. So just as an interest to everybody is what I was trying to say, but I think you have covered everything else, Dr. Karthik.
So I would like to take plain X-rays and the dynamic X-rays for the patients.
Still, lot of pain.
Yes, sir.
Dynamic exercise.
So she was while bending forward, she got more pain, sir. The movements were normal, sir. She was able to bend forward and touch without moving.
Excellent.
Now, which is demonstrated.
Extension moves.
Other than that, any other views? Simple X-rays. For any standing lateral view for anything, sitting lateral, supine lateral, can it demonstrate to an extent? If the patient is in severe pain.
Yes.
Simple standing X-ray, can it visit? Probably a past defect or anything like that, not a complete degenerative issue. Okay. So what are you going to expect on an X-ray, on an MRI or a CT, whatever you're going to do? What are you trying to see on this?
What do we from like disc?
No, X-ray, X-ray.
So, so X-ray you can look for any instabilities or any angular deviations as well. Instability we can see, so.
See, normally when you are taking an X-ray, you have to say what are you going to see in the EP view of the lumbosacral spine and in the lateral view.
Yes, sir.
Straight away you can't go and say I'm expecting instability also. You have to be very systematic.
Yes, sir. Yes. Yeah. We plain X-ray of lumbar vertebra along with the pelvis with the AP and the lateral views.
It's not lumbar vertebra, it's a
Lumbosacral spine with along with the pelvis and bilateral hips.
What do you see on EP view?
AP view, the spinous process scenes and the
So you said
The alignment
is being done. The spinous process has been seen there.
yes, sir. Yes, sir.
According to your palpatory findings, L3 to L5 lamina has been removed. That was the palpatory finding. Is there anything contradictory which you look at in the X-ray?
Spinous process presence.
See, you have to see the alignment of the spinous processes and you should see whether all the spinous processes are present. Okay. Now, the question is, are you able to see the spinous processes like T3, L4, L5 or any L5 is happening? So,
Huh? L4 lamina is not there. Which people they were operated?
So L5 is for levels. See, plain excessive.
For the clinical diagnosis, somewhere L3, L4, L5 is, that was the clinical diagnosis. Okay, synopsis, okay.
your level is L3, L4, 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 L4. So, clinically,
Yes, sir.
then what else you see on an EP view?
Yes, sir. Yes.
If D12 is the last two, what sir is asking is how many lumbar vertebrae are present?
One, two, L5, sir.
Huh?
L5.
How many lumbar vertebrae?
Sir. L5. So to D12, sir. L1, L2, L3, L6. D12, sir. L1, L2. Yes, sir. So second is
Which way you are looking at? Which way?
lateral windows.
So you have to look at the-
Yes, sir. So APV to seems cyclization.
So it's an APV, you want to see that sacralization or superposition, right?
Yes, sir.
Okay.
So basically, the transition which is actually like for
Yes.
what other important thing you will see on APV? What other structure you want to see? Even in this case, generally, you have to look the pedicles, okay? Pedicles, you have to see whether all the pedicles are there or any disease is there. So,
Yes, sir.
marker, right? Marker layer.
Mostly permanent.
Okay.
Yes, sir.
Yeah. Normally, you have to see the pedicles, okay?
Yes, sir.
In a normal AP view, the pedicles are oriented in an inverted funnel shaped appearance. Okay. So the interpedicular distance will progressively. Okay, clear.
CMC side, sir, can you unmute your mic, sir?
Yes, yes, we can hear you. Please go ahead. Did you ask a question?
We want to comment. Can you remove your comment?
Sorry, I can't hear you, Dr. Karthik. Comment about the X-ray or the MRI?
Comment, X-ray, basically what has been discussed here.
PowerPoint.
So we were just thinking this lady looks quite young to us. I don't know how. What is the age of this lady?
35.
35.
45, sir.
45.
Yeah.
So she was operated at the age of 30 then. 30 or 31.
Correct.
First. So yeah, now looking at the X-ray, I don't know. It looks is there a sacralization? There may be a sacralization. There is a narrowed 5-1 space. There is five spinous process is missing. There is no lordosis. But I would have preferred to have a standing X-ray. This looks like either a lying down or a sitting X-ray. This looks like a lying down or supine lateral.
Okay.
Apart from that, I don't know, sir. Is there any other finding, significant finding? There is no rotation, no list. So I'm assuming the AP view was, at least AP view also could have been supine only. The MRI also was shown to us. I just saw one section. I don't know whether you can make much out of it.
So you got a flexion extension there.
Yes, we saw the flexion extension view, and I don't know, there doesn't seem to be much movement on the flexion extension. There is no listhesis.
Yeah. And MRI.
I only saw one section, sir. Did you see more sections which you are not showing us?
We also got only 1 year.
Then you have to be really good to make a diagnosis on one film. I'm sure you're good enough to do that.
Okay.
The MRI, sir. MRI showing the protruded disc at the end. Sir. T2 weighted. Yes, sir. T2 weighted MRI, sir. Sir. The T2 weighted MRI of the lumbosacral spine, sir. Sagittal T2 weighted MRI of the lumbosacral spine, sir. With which shows protrusive disc at lumbar intervertebral disc at L4 L5 level, sir. And
Can you put the MRI on the screen back again, please, if possible?
are you able to see MRI, sir? Yes,
Now, with all these, what you have shown,
yes, sir.
when you radiologically, what are you looking at? What you presume you could have done? Now, I'm not here for your clinical
Yes, sir.
decision, that differs from the point of view what I'm saying here. So radiologically, what are you trying to read? What do you presume now?
So there's a large disc at the intervertebral disc prolapse at the L4 L5 level, sir, which could be the reason for the stimulus.
Reason for it was dystogenic. So what I presume here is L5 lamina has been removed. Probably the first.
Can we just turn the camera back to the screen, sir? Because or you can share screen, whatever you like, something you can do.
Stop share. Share. Kill share. Forward. Forward. Share.
Okay. Now radiologically, what I see is that
Yes,
it's
sir.
an X-ray. From this page is obliterated. L5 lamina is removed. Somewhere there is sacralization of L5 S5, S1. Probably what I presume is that you could have attempted a discectomy. It was complete and a postpartum fusion has been done at that level. Now what I presume is now this is an adjacent level disc disease.
Yes, sir.
And your complaint is stenosis, which is not matching with the age of the patient. She is just 40, 45. Okay. I think beyond, probably I would be thinking of stenosis or canal stenosis. Okay. Now I presume it to be as an adjacent level disc disease with a radical ectomy. So do you want to contradict or what are your findings or what do you want to support on a clinical diagnosis to that?
So it is a it's the same to sir. Yes, sir.
So what's your final diagnosis now after seeing this?
L4, L5 intraocular disc collapse with stenosis with bilateral right side radiculopathies.
So it's okay. As Denise has said, can you come back on to three-way of diagnosis?
No, sir. I think I agree with you. So this looks like I was just the only doubt in my mind was I heard the term adjacent segment. So in the absence of a fusion, can we call it adjacent segment disease? Is what I was not sure.
Yeah.
Yeah.
Yeah, I think now they're coming to a conclusion that this could be a recurrent disc or a possibility of recurrent disc happening at the second last mosaic segment. I'm not going to use term 3, 4, 4, 5, etc. because the segment is last segment is sacralized, and I don't see a categorical laminectomy effect as such on the MRI. You're not able to pinpoint anything on this. So that, or it could be as Ravi mentioned, could be a adjacent segment. This new segment other than what they are operating, leading on to a stenotic symptom with radiculopathy on the right side.
Yeah.
That will be the final conclusion from our side. Would you agree with that?
So that is the other thing, Dr. Karthik. I was just thinking, all my learned colleagues there, that if there is a sacralization, it usually means that that disc at that level is vestigial. It is non-functional.
Correct.
So it is very unlikely that she would have had a L5S1 disc herniation because you don't have much of a disc to start with.
Correct.
So I don't know what has been done at 15 years back, to be very honest. Like you said, you also pointed out that there doesn't seem to be a evidence of a scar or a laminectomy defect at that area.
Correct. So, and there's no X-ray doesn't show any evidence of a LC fusion also. So it's the want of better terminology laminectomy. Hopefully nobody's okay. So I think we'll conclude with the diagnosis saying that it's probably a disc at the partially narrowed segment. They labeled 3-4. We use the terminology internationally as the last mobile segment. Concerning the last mobile segment, here L5S1 is sacralized. Okay. Yes, sir. We'll tell that. What's your treatment plan?
Oh, she's got neurological deficits, sir. So she has neurological deficits.
No, we differ with that.
Yes, sir.
We are not agreeing with the fact that she got a deficit. Okay.
Yes, sir.
So we take her out of the mind. Now she's got a discogenic backache.
Yes, sir.
On a narrowed segment. So what do you want to do then?
So keeping in mind that if he does not have any neurological pain, I mean, if he does not have any neurological deficit, we can manage. We can try conservative management initially, sir.
So how long would you want to manage a disc collapse conservatively? You will wait for about 3 weeks time.
Yes.
Okay.
Yes.
Beyond 3 weeks, all of us get reach to do something.
Yes.
So if you have to do something,
yes, sir.
Proactively, what will you do?
We'll go for discectomy, sir.
Is there any other intervention you would like to do before putting a knife on? Remember, two things that happen in this patient. Already had a surgery done, you don't know what surgery. So you must be worried what you're going to do. You're going in second time.
Yes, sir.
Okay.
We'll go for yes.
So what are your presumable causes of pain generators in this?
She's got discogenic pain, sir.
Okay.
And,
So how will you now look at a diagnostic intervention?
you go for an endoscopic.
Huh? Diagnostic intervention.
So diagnostic.
So do you want to do an epidural or nerve block
You go for epidural steroids.
near this?
You go for epidural nerve blocks.
Go for that. Okay. That's one option. Right. So if you got no relief, then it gives you another option. So surgically, what do you want to do?
You go for open and discectomy, sir. You go for discectomy and fusion. The interbody fusions.
Okay. It's got unilateral pain.
Yes, sir.
So you could still think in terms of if you first find that area is a virgin area and there's nothing else done, you would certainly look for a discectomy in that. If it's being operated, I don't see any telltale signs of surgery in this in terms of laminectomy or laminectomy in this area. So if that were the case, then you could think in terms of a revision discectomy, which could be either micro or endoscopic discectomy, theoretically. For which you can think in terms of doing posterior decompression instrumentation with a interbody fusion. Okay.
Yes.
So that'll be a sequence of events.
Yes.
So I think we'll stop there.
Yes.
Any your sir, your opinion, sir? Any do you want to differ with this? Sir? CMC, sir, okay, sir. Can we go to next case?
Yes, please proceed. Please proceed.
Okay. Thank you, sir.
So we are now already at 1:20. So we wanted to know, we have a interesting case on PowerPoint.
Yes, sir. You are waiting for that, sir.
Or we also have a live patient, a cervical spine patient. What would you like us to do?
We'll go for a long case, sir. I think cervical spine case, so that will be better.
All right. Okay, good. So yeah, we'll just get the patient. Just give us 30 seconds, sir. So, just wanted to ask you, while we are setting up this patient, what was the indication for fusion in the last patient, sir? Why are we talking about fusion in the previous patient?
Yes, presumably we just said the sequence of thought process.
Okay.
When you expose, you said the primary disc, you do a discectomy, revision. Again, you find that there is no significant scarring. You got a revision discectomy. If you find a significant scarring in the knee, you look in terms of doing a decompression with a fusion in terms of a revision surgery. So if you're doing a revision surgery, we look at doing a revision discectomy, post-stabilization with a TLIF following the
Sure.
discectomy.
Understood. Thank you. So this is our Dr. Arvind is one of our senior fellows, and he will present this cervical spine case.
So good afternoon to all. Today I'm going to present this case. Is a 35-year-old male right-hand person from West Bengal presented with chief complaints of
A little bit slower. We are not able to follow you. Yeah, please go slow and
yes. Speak slowly.
speak slow and a little bit louder, please.
Tightness in the lower limbs for the past 2 months and difficulty in walking for the past 2 months.
Sorry.
Is it audible, sir?
Yeah, somewhat better. Yeah, now you please go ahead.
Yes, sir. So tightness in the lower limbs for the past 2 months and difficulty in walking.
Tightness in the lower limbs.
Yes, sir.
Okay, for the past
2 months.
2 months. Okay.
And difficulty in walking for the past 2 months.
Okay.
And paresthesia and numbness in the left upper limb, inner aspect of the forearm for the past 2 months. And
okay.
Difficulty in urinary micturition for the past 10 days.
Past 10 days. Okay.
So patient was apparently normal before 2 months, following which he has developed tightness in the lower limb, which is insidious, progressive, and associated not associated with any pain. It's also patient first felt the tightness in the left lower limb first, followed by the right lower limb. And the patient also have a difficulty in walking for the past 2 months, which is insidious, progressive. Before that, 1 month, he was able to walk without any.
A little bit slower, doctor, please. Yeah, you are running for a little bit slow, just a little bit slower. Okay.
Okay.
Right.
So he was able to walk in a flat surface without any support or any assistance. But for the past 1 week, he need assistance to walk the flat surface and even in the climbing stairs also. So the patient also complains of paresthesia in the left inner aspect of the forearm for the past 2 months, which is associated with the current-like sensation on and off for the past 2 months. So it's not associated with any type of pain. Patient also complains of difficulty in micturition. The patient feels that he is not able to completely evacuated after stop micturition, but there is no complaints of initiating difficulty in initiating the micturition or a stoppage of the micturition. But no need to able to get up in the night due any urgency in the urinary. The patient also complains of neck pain for the past 10 years, which is insidious, progressive, dull aching, and non-radiating pain, aggravated with his tailoring occupation and relieved with medication. He was on and off medications with oral analgesics for the past 10 years. So patient knows no complaints of any difficulty in combing hairs or difficulty in holding objects or difficulty in buttoning shirts or mixing the foods. No history of any buckling of the knee or slippage of the footwear while walking. The patient is able to appreciate the cold and warm water while taking bath, and no history of trauma, no history of fever, no history of constitutional symptoms and the weight loss, chronic cough, contact with the TB patients, and similar past history, no significant family history. And the treatment history is taking only the oral analgesics for the 10 years for only the neck pain. And his activities of daily living was severely affected. Now he is dependent on other persons for the normal walking. And his occupational and recreational activities are severely affected because of the complaints. So summarize wise, this is the 35-year-old right-hand person from West Bengal presented with tightness in the lower limbs with the difficulty in walking and urinary mixation for past 10 days with no history of trauma or any other significant personal history or past history. So with severely affected activities of daily living.
Any of syncopal attacks or blurring of vision, something?
No, sir. No, there is no any syncopal attacks, and there is no any history of any sensory attacks or symptoms like whenever he is facing, closing the eyes.
Yes.
Yes, sir.
Patient doesn't have. Okay, right. Yes. Okay, now go back to examination. Past, yes.
Yes. So, I mean, the examination wise, higher mental functions are normal, cranial nerves are normal, vital stable. So gait wise is unaided, unassisted bipedal, broad-based spastic gait. And other general examination, he has bilateral in the left hypothenar and thenar muscle wasting. And local examination wise, the head is in the center over the trunk and the sacrum, with no tilting or asymmetrical, no scar or sinus, no deformity, and no spinous tenderness or paraspinal tenderness. The movement or full range of movements with painless. So coming to the neurological wise, bilateral upper limb tone was normal. Lower limb tone hypertonia MA modified Ashworth scale, grade 2. And the reflexes, bilateral biceps reflex are present, and bilateral inverted radial reflex, and triceps, knee, and plantar reflexes are exaggerated with the plantar clonus and ankle clonus. And power wise is having a C5, C6, C7, and right and left side is completely 5x5, and left side C8, T1 is 4x5. Bilateral lower limbs also is having hypertonia, MAS2. So sensory wise is having reduced sensation in the left C8 and T1 by 10% for the pain, light touch, pain and temperature. And the posterior columns examinations or vibration, vintage pressure, everything is normal. So myelopathic signs is having a Rombaught's positive, a Tromner's signs positive, bilateral finger escape sign is negative, finger grip release is 20 per 10 seconds. Is having a Rombaugh sign is positive, and tandem signs is not able to do. And bilateral plantar reflex as extensor. So other special tests, Sperling and Lermity signs were negative. And a rectal examination, anal tone, perianal sensation, and voluntary anal contractions are present.
Okay. Have you heard of scapulohumeral reflex? Have you heard of?
Yes, sir.
Okay, is it there in this patient?
It's normal.
Okay, what does it indicate actually?
It's indicated the lesion of the myelopathy or cervical lesion is below the C3.
So here it is not there.
No.
So okay. It is present. Scapulohumeral reflex is present.
Present, yes.
Okay. Right. Okay, you summarize your finding. What is the probable diagnosis now?
The probable diagnosis is extradural compressive myelopathy, probably due to cervical degenerative disease with the incomplete motor C8 with incomplete sensory C6.
What is the age of the patient you said?
35.
35. Okay.
And other differential diagnoses are intradural compressive myelopathy, probably due to intraspinal tumors.
You said patient is having a pain. Generally, intradural, I don't think patient is having a pain. More pain component will be there. Okay, you. Right.
This patient also having neck pain on and off for the past 10 years only. The pain is major complaint.
See, in the history, initially, patient started with a neck pain. Am I right? If I am right, it started with the neck pain, then gradually difficulty in walking, then slowly it involved the bladder and bowel. Am I right?
Yes, sir. But the patient's current complaint is not about the neck pain. This neck pain is almost for the past 10 years. For 1 week, whenever he's doing the tailoring activities, it will aggravate. Again, after taking the oral medicines, it will decrease. So now the 2 months is the tightness and the difficulty in walking is the major complaint.
Okay, right. What's the probable diagnosis? So you told the diagnosis, no?
What is, just repeat the diagnosis?
Repeat the diagnosis, please.
Yes, extradural compressive myelopathy, probably due to cervical disc, cervical myelopathy, cervical disc degeneration with the motor incomplete C8 and incomplete sensory C6 with the cervical MJO of 11/18.
Okay, you reasonably summarized everything, right? Then how will you proceed with this patient now?
So I'll get a X-ray of the cervical spine, anteroposterior and lateral view.
Okay.
Do you have
the X-ray?
Show the X-ray. So while the X-ray is being put up, one point which you said that the pain has come down and then the other symptoms have started. So that is for the postgraduates, that is important thing. Even in the lumbar spine, a patient with a lumbar disc herniation will start with back pain because of stretch of the annulus and the pain sensitive fibers in the periphery. And after the annulus ruptures and the nucleus comes out, then the tension on the annulus comes down. So the pain comes down, the back pain comes down and the leg pain starts. So that temporal profile of symptoms is very important, that you start with back pain keeps going up, back pain will then stop and the leg pain will start. Once you have a symptom complex like that, you can almost be sure that you are dealing with a disc herniation. So Arvind, also, it is not degeneration, it is herniation. There are many components to degeneration. It can be just neck pain also is degeneration. But here you have arm pain starting. So that is a herniation with impingement of the nerve root. Yes. So now why don't you read the X-ray?
So this is the X-ray of cervical spine, AP and lateral view, including the Atlanta Hospital junction. It's a adequate X-ray. We can able to see up to the T1 lower end of the vertebra. With alignment wise, all the 4 lines of the cervical spines are intact: anterior and posterior spinolaminar line and the spinous process laminar line. And the prevertebral shadow in the C2, C3, C6 even looks appear normal, and the lumbar cervical lordosis appears to be normal, and I can see some degenerative changes in the C5 lower end of the body with the occipital junction. I can able to see the approximately there is no any basilar invagination, and atlanto dense interval and posterior it looks appear to be in the X-ray.
So maybe there is a little bit of loss of cervical lordosis. I don't know. Did you find a lot of spasm when you were examining the knee,
No.
the neck?
No, sir.
No? Okay. Because if you find spasm, then you can correlate it with a straightened cervical spine. So I'm not seeing a lot, but like you said, there is some early degeneration, maybe some disc space narrowing at 5-6. Apart from that, I'm not seeing anything much. Would our colleagues in MMC like to say anything about that X-ray, sir?
No, but he mentioned a degenerative cervical spondylosis. We don't find anything. Space is maintained. We don't find anything. Any degenerative component is there. Maybe pure disc. Yes. Okay.
Okay.
Nothing more to add, sir. Yes, you can.
Yes.
Okay. So further, I will get a MRI of the cervical spine. So this is the MRI of the cervical spine, T2-weighted sagittal images showing central and parasagittal images, showing the disc bulge and compressing the cord at the C5, C6 level with the myelomalacia changes. We can able to see the hyperintense in the cord at the C6, C7. It extend up to the C4 body level. So axial images. So this is the axial images.
So there's this 5-6 disc herniation with significant cord signal changes.
Right.
So
Right side.
what do you think, sir? The total history is how long?
For the past 2 months.
2-month history and so much of cord signal change. I don't know, how does that affect your thinking? Professor Tanigamani, Professor Karthik, Aju, anyone?
But his main complaint initially he said his pain is present for the past 10 years. Now his myelomalacia changes is getting. I think we have to see some more cuts. Can you show me the sagittal cuts? Some more sagittal cuts.
Sorry, we don't have. Okay. We don't have any more. Huh?
Okay.
I think myelomalacia change can happen. Not an existing discussion which is an acute exacerbation. That is not to happen.
Sorry, I missed that, Dr. Karthik. What were you saying?
No, acute myelomalacia change.
Yes.
And acute exacerbation following a degenerative disc which is present for long division, is known to happen.
Yeah.
But Raju wants, sir, anything like Hirayamas?
Sorry,
Any flexion MRI is there?
no,
No,
we don't have a flexion MRI. We don't do flexion MRIs here.
Okay, sir. Was there any wasting, sir? I think in the history, wasting was being described on this patient.
please.
What is the hospital number?
No, sir, it's a dynamic cervical compression. The other way you can't explain, you don't have much explanation for it. At least in particular position, inflection, if the cord may indent over the disc, and when it is happening recurrently over a period of years, it can cause a myelomalacia.
Yeah, we'll just try to give you some more sections of the MRI.
Any CT was being done, sir?
Do we have a CT scan?
No.
We don't have a CT yet. Yeah. So, so you have imaging findings that are out of proportion to sometimes to his symptoms. We'll see if we can give you some more images. Just can you magnify that a little bit? If you can, yeah. Yeah, go back. So, what would be the role of a flexion MRI here, sir? What do you think?
Sir, sometimes in a neutral position, even though there is a significant amount of disc, it doesn't get, the cord is free and doesn't compress. So when the patient adopts a flexion posture, that can impinge on the cord and cause repetitive impingement can cause myelopathy.
So if you look at the axial view also, there is some compromise of the canal, but it is not fantastic. It is not spectacular. So would you still, what would you advise in a situation like this? What are the treatment options, Arvind? What do you think are the treatment options?
People think that disc is the major component causing that compression and cause for the myelopathic change. So the goal of the treatment is to decompress the cord by doing removing the discectomy and fuse that level using a bone graft, or we can use the cage to maintain the disc space height. So I would like to do the anterior cervical discectomy and fusion.
Yeah, so I think all of us will reasonably agree with the plan, but what is different about this patient as compared to every other patient that you see with this kind of problem or for whom you advise this kind of surgery?
The prognostics of the...
Yeah, so you have to have a big conversation with this guy that his symptoms may improve to a very variable extent, very unpredictable. So in him, the counseling is the main thing. Has he noticed any improvement, spontaneous improvement over 2 months, or is it worsening?
Worsening.
It's worsening? Okay. What is the role of steroids, do you think, sir, in this situation? How would you use steroids routinely?
Can I ask you a question? Would you think in terms of doing a second
Is there any role for steroids?
No, we don't use steroids.
Therapeutic steroids?
No, we don't, unless, no, generally we don't use steroids. I was just thinking, following the anterior surgery, would you still look at doing posterior?
Posterior for what? For decompression, sir? Or for a long segment decompression?
Not a long segment, 2 segments. But I do find there is a echoic signal of the posterior aspect happening from C5, C6 to C4.
Yes.
On the posterior aspect. So maybe valid from the gene's point of view that the CT scan probably would be a necessary investigation before operating on him to see the evolution or ongoing of a PLL kind of a scenario on this. And then the role of posterior, I don't know. Still want your thoughts on
No, I mean, I understand what you're saying, sir, but the only thing I have seen sometimes multiple sclerosis and all presenting like this. A young person with a long segment hyperintensity with a small disc, which may or may not have been the cause. So I don't know whether there is a role for getting a neurological opinion for something like this.
Yes, you are right, sir. I think the CT, okay, I feel CT can be taken in this case to have because the extent of decompression that may be needed on later stage. But before that, as you said, it is better to get a neurological opinion also for a completion. Right? That's what I think.
There is a little bit of mismatch between the degree of compression and the degree of cord damage.
Moreover, it is progressive. He says it is progressively they were getting worsened.
Yes.
Yes.
Any other thoughts, sir? Do you want to demonstrate any of the signs on this guy? Does he have, what signs does he have, Arvind?
Patellar pronus is there.
Okay, just show, can you just focus the camera on it? We'll quickly go through the gait. We'll also look at the gait. Can you focus the, Arvind, go on the other side. The frontal. So how many beats per minute is normal and how much is abnormal, Arvind? You're off.
More than 5.
5 is normal or abnormal?
Abnormal.
5, huh? Okay, I used to think it is 3 or 4, huh? 3. Well, what is the consensus, sir? What is normal and what is abnormal?
More than 3, I usually take.
I think 3 is.
Yes.
3 is 5 is too much, I think.
3.
Can you see the? Okay. Anything else you want to show us? What about the lower limbs? Sorry, the ankle. Yes, Dr. Karthik.
After lower limb, you go to upper limb and demonstrate Hoffman.
I can't understand. Hoffman, can you show the Hoffman, please? Yeah. Yes, can you just focus on the camera, Arvind? Just turn this way. Yes. No. You're hiding it. Yeah.
You're hiding it. Yes.
So what is can you describe the Hoffman? What is the description of the Hoffman? How do you do it and what response are you seeing?
Please the middle finger of the.
So you stabilize the middle segment, you flex the distal segment, and then you suddenly let it extend. And what are you looking for?
Look for the flexion of the thumb and flexion of the other adduction of the thumb and flexion of the fingers.
Okay. Right. Anything else you want to show us? Is there clonus?
Ankle clonus.
Ankle clonus? So you allow the gastroc to relax. So you flex the knee a little bit, okay? And then you give a few dummy movements, and then you suddenly give it a full jerk to disorient his brain. Otherwise, he will stiffen it. थोड़ा loose करो बाबू, ढीला loose. Okay. Okay, why don't you demonstrate? What do you want to do? And just explain what you're doing now.
I'm going to perform the brachioradial reflex. I'm going to tap the tendon of the brachioradial reflex. The normal thing is you have to do the flexion of the elbow. Causing the flexion of the fingers instead of the flexion of the elbow. It's an inverted radial reflex. So
What is the reflex you're examining now?
Shimoshu scapulohumeral reflex.
Okay. At what level it is positive?
At what level?
What level pathology there is Shimozu's reflex positive?
More than C3. Above C3.
Yeah. Okay. Okay. And what is your inference of your brachioradialis reflex supinator?
It's an inverted radial reflex.
Inverted supinator.
Yes, sir, inverted supinator.
Okay. Okay. So what is spillover phenomenon?
So spillover phenomenon is the same pathology as a inverted radial reflex. Usually they will have the flexion of the elbow, but this patient, they will have the extension of the fingers.
Okay. Okay.
So the gait.
We will just demonstrate gait also and see. Move the. उधर चल के आई. So what are the components of gait, that abnormal components of gait here, Arvind?
Abnormal. This is a spastic gait. They can able to see the lower limbs is kind of components of scissoring, and broad base gait with low stride length and low stride velocity. And the patient stay low stand space when we're landing on one leg. So it's more of a spastic.
So this is a kind of a sensory ataxia. You can see him, if you can see his face, if you see his face, he's looking at the ground. So normally when we walk, we don't need to look at the ground because there is enough proprioception coming and we can look straight. But this patient has got a sensory ataxia because of posterior column involvement. So he needs to compensate for that by looking at the floor. So you must understand the gait is a component of spasticity because of corticospinal tract involvement and loss of proprioception because of posterior column involvement. So it's a combination of both of them that is giving him this gait, which is a myelopathic gait. Yeah, I think that's okay. Any other questions, sir? Dr. Karthik, Dr. Tanikabani?
No, sir, you have covered almost everything, sir, with the clear demonstrations. Thank you, sir.
Thank you, sir.
Thank you very much. Move the bed to the side, please.
Sir,
We have just 2 minutes left, sir. I don't know whether we have time for a PPT. We may not have time this time, but maybe we can do it next time. Whatever you say.
Okay. Yes, sir.
thank you, sir. This is Dr. Pasupati from MMC. On behalf of Madras Orthopedic Society and MMC, I thank Professor from Chennai David and Dr. Venkatesh sir for joining with us for the wonderful clinical demonstration. Nice cases, sir.
Yeah, thank you very much. Dr. Venkatesh had to step out. His son got injured while playing football or something, so he has just gone to look after him.
Okay, sir. Okay.
I request Corona Form to honor our Professor Kenny David.
Okay, I got it, sir. Thank you very much.
Okay, thank you, sir. Thank you, sir.
Thank you very much.
Thank you, sir. I request to honor Professor Venkatesh, sir. Kindly honor Professor. Oh,
Yeah,
he's
yeah,
not
we'll-
there. Okay.
I'll
So,
make sure.
you can get it for us.
This is for
Venkatesh. Okay.
Thank you.
Thank you, sir.
All right.
I request Professor Pasupati sir to honor our Professor Karthik Kailash sir. Sir, one. Sir, முன்னாடி வருங்க சார் முன்னாடி வருங்க அங்க அங்க இந்த பையன் பையனை
Thank you, sir. It's a wonderful clinical discussion that Arvind presented very interesting case and it was a very nice presentation elaborate. I congratulate him for his wonderful presentation. And Dr. Vishwant also, he was the person coordinating this program also. And he also did a very good effort. I congratulate him also. And thank you for the wonderful clinical case discussion. Yeah. But
thank you very much, sir, for this wonderful event. So with this, I think we can conclude. Thank you, sir. No problem.